Bismillahirrahmanirrahim. Assalamualaikum and good evening. We will start endocrinology today, and I will be starting with a very important topic, which is important for both FOP and class. That is the diabetic ketoacidosis, DKE, and you will get so many questions in the exam on this one. Okay. Okay. Great. So what we talk about today is the diabetic ketoacidosis. First of all, let me give you the concept of what is diabetic ketoacidosis. Okay, so we have a diabetic patient, we have a diabetic kid. All right, our diabetic kid who got infection. All right, who got any infection like gastroenteritis or any infection. Whenever he got this infection, the diabetic patient, whenever he got this infection, his body goes into stress. He is stressed with this infection. Okay, so what happened? They develop insulin resistance. If he is on insulin, that is the type of diabetes. So insulin resistance develops. All right. Secondary to this insulin resistance, these are the cells. These are the cells of the body, and we all know that cells need glucose for the production of energy, for the production of ATP. So if insulin resistance develops secondary to infection or secondary to stressful conditions in a diabetic child, then what happens that in secondary to this insulin resistance, the glucose, it is unable to enter into the cell, and cells cannot utilize this glucose for the energy production. The glucose, it remains outside in the extracellular fluid in the blood. This is the, suppose this is the blood, the glucose, it remains outside the blood. And as a result of this infection, we can have this hyperglycemia. All right. The water, it moves out of the cells just because of this glucose, and the sodium, it got diluted. So hyponatremia also occurs. Increased glucose, decreased sodium. And what happens, this is a mechanism by God, that the cells have to live, cells have to survive. So for their survival, they produce their energy from the fats, from the breakdown of the fats. And if glucose is unavailable, they break down the fats in the liver and produce ketones for the energy. What they produce ketones for the energy. Secondary to the production of these ketones, the medium in the body, it becomes acidic. All right. The whole blood, it becomes acidic. pH, it is reduced and it becomes acidic. So what happens? There is metabolic acidosis. Okay. In diabetic ketoacidosis, how is the presentation? How is the presentation of the child? Let me tell you the presentation of the child. This concept I wanted to give you before starting the right management, so that would be okay. What happens? Usually the diabetic kid, they present with the abdominal pain abdomen. They present with the pain abdomen. They present with the hyponatremia. They present with the vomiting, and secondary to the vomiting, they are dehydrated. All right. These ketones are very toxic if they remain in the blood, and they need to excrete the ketones via the urine. They need to excrete the ketones from the body. All right. So the body, it is in stress, it is producing ketones, the body is going into acidosis. There is the small breathing, that is the deep breathing secondary to the metabolic acidosis. Okay, the small breathing signs. The patient may become confused. The patient may got into coma. Coma. Okay, this all happens secondary to this infection, and there is raised anion gap metabolic acidosis. For the raised anion gap metabolic acidosis, we have different differentials, and one of the differentials in the diabetic patients is the diabetic ketoacidosis. Right? Okay. Okay, why diabetic ketoacidosis? It is a bad signal. It is a red signal because it shows the diabetes is uncontrolled. The diabetes, it is going uncontrolled. Yes, due to poor adherence, one can go into the DKA. Due to metabolic disturbances, due to drugs, one can go into DKA. From infection, there are various drugs, various poisoning in which one can go into the DKA. So this is a bad signal because it shows the patient is getting ill. Patient is getting ill. The patient is not fine. Patient is producing more ketones, which can be toxic for his body because ketones are making the body more acidic, the medium more acidic, and you need appropriate pH in the body to work properly. So this is a bad signal. All right. Okay. If you understand the mechanism by which it is occurring, then management, it becomes easy for you. So management, it is the game of actually controlling the blood glucose. You have to control the glucose. You have to make this glucose enter into the cells. You have to remove the ketones. You have to remove the ketones from the body. You have to balance the electrolytes. That is the sodium and potassium. You have to balance the electrolytes. Okay, for controlling this glucose, we can have two targets. One is that glucose, it is not entering into the cell. All right, so to make it enter into the cell, you have to give the insulin. Okay, how much you give and how you give, there is guidelines depending upon the level of this glucose. We have the guidelines. We will be discussing in a while about that. Secondly, you have to give glucose from outside. Okay, why from outside? Because if you give it from outside, the body will be utilizing this glucose and ketones production will be decreased. All right, ketones production would be decreased. For the balance of the electrolytes, you need to balance the potassium, you need to balance the sodium, and you have to treat the dehydration. If you treat the dehydration along with this electrolytes and glucose, it assists the whole procedure and the body is gonna heal. All right. So basic thing is this. Okay, your goal is to decrease the glucose in the blood and you have to enter that glucose into the cell. You have to remove the ketones. That is, you have to make them less than 0.5. You have to keep the pH towards normal. That is, you have to make it towards normal. In diabetic ketoacidosis, it is more acidic, and we can say that it is less than 7.3. It is less than 7.3. If it is less than 7.1, then it is severe dehydrated state. That is 10% dehydration. We consider it 10% in case of 7.1, less than 7.1 or equal to 7.1. And if it is more than 7.1, then it is 5% dehydrated, and we correct this dehydration according to this 5% and 10%. We have to calculate the deficit, we have to calculate the maintenance fluid. So basically this is the scheme. Now see how you proceed. I have given you the initial, you can say backup concept. Now you have the concept in your mind that what is your plan in treating that patient. And now we will also see the levels and the values which we need to correct and how we move our scale according to those values. All right, suppose you are sitting in the PICU or HDU and you are treating this diabetic ketoacidosis patient. How is he presenting? Because the child is diabetic, so of course that the signs of diabetes is thirst. Weight loss is secondary to dehydration. Okay, then polyuria, which is a sign of diabetes, we know. Yes, the child can present with abdominal pain and vomiting. This is very typical symptom of this diabetic ketoacidosis. The child is tachypneic with a small breathing. The small breathing is sign breathing, which is a sign of being metabolic acidosis. All right. There is smell of ketones from the breath, ketone breath. Okay, the patient is dehydrated, he goes drowsy and even into the coma. You have ketones in urine or blood. In blood, of course, we can find ketones, and body tend to excrete the ketones. So we also find in the urine. You have the elevated blood glucose. Why elevated more than 11? Why? Because glucose, it is not entering into the cells and it is remaining outside the cells. That's why its level is increasing in the blood, which we have to correct by giving insulin, and we also give glucose along with that. So to produce the productions of ketones, okay? And there is acidemia, that is the pH is less than 7. Give me a second. Okay, so what happens? Okay, so now suppose this patient came and I am on duty. Now this is the patient. Now how I proceed, what I will do, first of all, as the patient came in coma or he is drowsy. So I start with the basic ABGs. I check the airway, breathing, circulation. I record the vitals, all the vitals, okay, the pulse, heart rate, respiration rate. I will look for the conscious level and signs of cerebral edema. Why cerebral edema? Because sometimes this what we say gastroenteritis, vomiting and diarrhea. If the rapid correction of the fluids, if someone did this rapid correction of the fluid, it can lead to this complication of the cerebral edema. So we have to look for the complication. Okay, there is headache, confusion, irritability, abnormal movements, high BP, variability, small, irregular frequency. Why this? To see for any poisoning like the salicylate poisoning or some drugs, some recreational drugs can also cause this diabetic ketoacidosis. All right, infection, yes, very important. You have to see for the focus of the infection. Okay, see for the height and weight. Why weight? Because you have to monitor the dehydration with this weight. Estimate the dehydration. How? If pH is less than 7.1, it is 5% dehydrated, and sorry, it is 10%, and if it is above 7.1, then it is 5% dehydrated. You have to replace this dehydration slowly over 48 hours, okay, not quickly, because quick replacement of the fluid leads to this cerebral edema. All right. So each and every word of these guidelines is important. Assume 5% fluid deficit if pH is between 7.1 to 7.2. And if it is below 7.1, means very severe acidosis, then it is severe DKA, and you have to calculate fluid deficit like 10% dehydrated. Okay, clear up to there? Okay, next is okay. This is investigation. We all know you have to pass two cannulas. You have to do this blood glucose, FBC, blood gas, HbA1c, blood. This blood ketones is important. This blood glucose is important. Ketones is important, and this electrolytes is important. Okay. Also see the infection focus. You can go for the cultures of blood and urine. See for the signs of the meningitis. If there is signs, then go for the LP. Also see for the liver function test. Okay. Okay. For task exam, remember this GAD antibodies is important. GAD antibodies, they are more specific for the type 1 diabetes mellitus. Okay. This is your task exam question. GAD antibodies for type 1 diabetes mellitus. Now you don't forget this, okay, for the rest of your life. Okay, what you check? You check for thyroid function, CBF, ICE antibody, thyroid, immunoglobulin, this GAD antibodies. So all work of you do. Okay. Okay, now coming towards important thing, that is this algorithm. Yes, this is important. You have to assess, and what you assess, you have taken the history as I have discussed above. You just examine the patient, and if you suspect the diabetes, then you have to do the test. And for test, you suppose you did blood glucose, it is more than 11, and your pH is less than 7, means metabolic acidosis and elevated glucose, so it is more likely. With ketone, which is more than 3, remember these values, okay? So it is more likely diabetic. Ketoacidosis, you took the blood for electrolytes as well. Okay, so confirmatory, after confirmatory test, you call the senior staff according to these guidelines, and then you see if the shock is present or if the shock is not present. For assessing this, you can palpate this. You have to see the pulse. If the peripheral pulses are reduced volume and if there is reduced conscious level or coma, then you can suspect this shock. Shock management is different and without shock management is different. Actually, what happens whenever there is shock, then you have to give this bolus of sodium chloride 20 ml per kg. Okay, this bolus, as the patient is in shock, this bolus of 0.9% 20 ml sodium chloride will give, which you do not, okay, do not subtract at the end. Similarly, if the patient is not in shock, you also give 10 ml bolus, 10 ml per kg bolus over 30 minutes, but you have to minus this 10 mg at the end from the fluid which you are gonna give to this patient. You now calculate the fluid requirements and you correct the deficit over 48 hours. Okay, we have the formula below for the deficit, so don't worry about that. Just remember, most of the time they ask you what fluid you have to give in the diabetic ketoacidosis. It is in the equity exam, which is the task exam, in the fourth exam. So remember this 0.9% sodium chloride with 20 millimole potassium chloride in this, remember this 500. Check serum potassium if it is normal and ensure urine output first. Okay, insulin, remember this 0.05 to 0.1. We adjust this according to the levels of glucose and you give it by infusion. You won't give it bolus, okay? Insulin is always given in infusion, not in the bolus. It is given over 1 to 2 hours after commencing the IV fluids. First, you have to put the IV fluids, then you have to start this insulin. Okay, so this is about pH less than 7.3. This is the mild 5% dehydration. Less than 1, 7.1 is more ketoacidosis, it is severe DKA. You have to correct this for 10%. What you have to monitor? Very easy. Of course, you have to monitor glucose. Of course, you have to see for the neurological status, input, output record, ketones and electrolytes, 2 hourly after the start of the IV therapy, and then 4 hours. Initially 2 hourly and then 4 hours. Okay. So now this is easy. How you calculate the deficit, how you calculate the maintenance, I will be discussing in a while. Okay, don't worry about that. Just remember, if there is signs of cerebral edema, what are the signs of the cerebral edema? It is a very serious complication of this correction of fluid. Okay, patient complain of this headache, or he become irritable, or heart rate becomes slow, that is the bradycardia, or there is reduced conscious level, or signs of raised intracranial pressure. Okay, so it means cerebral edema is developing. If there is neuronal deterioration, we have to manage the cerebral edema and exclude the hypoglycemia. How you correct this? You give sodium chloride. This is 2.7%, 5 ml per kg. Oh, yes, this mannitol is important. Mannitol in case of the cerebral edema. This can also be your exam question. They can ask you what drug is given in the cerebral edema and what is the dose. So it is the mannitol 0.5 to 1 gram per kg. It is given over 30 milligrams, over 30 milligrams if required, and then dose can be given. Always involve your senior staff whenever there is a serious complication. So as a junior doctor, you always have to involve your senior staff, and you restrict the IV fluids by 50%. Okay, in case of this edema, you have to decrease it by 50%, and you discuss with the pediatric critical care. If there are signs of improvement, yes, if it is improving, then check for the blood glucose. And if it is not improving, what makes it, if the patient is static, if they are not decreasing the ketones or glucose is not decreasing, it means the status is not improving. If not improving, what you have to reevaluate, check for the fluid balance, check for the IV therapy. If continued acidosis, further resuscitation fluid is required. Correct the insulin dose. Consider sepsin in case of not improving. Suppose it is improved. Now what you do, you check for the glucose, and it is less than 14. Okay, remember this value, less than 14. If it is less than 14, then you have to commence the IV therapy. Later on, you switch this IV therapy to subcutaneous therapy. So you have to remember this value less than 14. If less than 14, start 0.1 unit insulin. Okay, reduce to 0.05 unit per kg per hour if it is improving, and also give glucose along 5%, 5% glucose. Okay, this is the IV. The patient cannot take oral. Give 5% glucose, and you give sodium chloride 0.9% with 20 millimole potassium in the 500 ml of food. All right. Now see the blood glucose. Now it has fallen below 6. If below 6, it means glucose is decreasing. So common sense is, if glucose is decreasing, then add more glucose to sodium chloride solution. And if ketones is still more than 1 millimole per liter, do not. See the ketones? Okay, you see the glucose and you give the glucose. You see the ketones and you manage this insulin. If ketones is still high, do not stop. Do not reduce the insulin below this. Remember 0.05. Do not reduce this. Okay, suppose the blood glucose is not going down. Then again you have to monitor. Then again you have to monitor. Okay, this is same. Hourly glucose, neurological status, intake, output, blood ketones. Okay, this is almost same. Now see, you have given all these measures and DKA is dissolved. Oh, thank God, DKA is dissolved. Yes, it is dissolved. No ketones. All right. Ketones are resolved, glucose is normal. So now you can switch to subcutaneous insulin. Okay. Now you can switch from IV to subcutaneous. But after stopping this IV insulin, if 1 hour passed, 1 hour has passed, now you start this subcutaneous insulin. What are the signs of resolution of drinking? You see the patient is getting clinically well, he is drinking well, that's good, he's tolerating food, and blood ketones are resolved. Okay, okay, just digest whatever I taught till done. Okay, now coming towards the immediate treatment. There is the criteria of admission to this high dependency unit and PICO, pediatric ICU. There is a difference, all right? If the patient is alert and if the patient is not in shock, you admit in the high dependency unit, but not in the ICU. But if the patient is in shock and the patient GCS is less than 8, then you have to admit in the pediatric ICU. In the pediatric ICU, you have to address this pH, which is very low, which is very acidic, and this marked hyperventilation. You have to do something for this hyperventilation. Or if the child is younger, its age is less than 2 years, then of course you have to admit the patient. If in shock, then PICU. If not in shock, then HDU. But you have to admit every patient who is less than 2 years old. Okay. Generally, what you do, you make them NBM, nil by mouth, for the first 8 to 12 hours. If vomiting, abdominal pain, no bowel sounds, or decreased GCS. If vomiting, pain, no gut sounds, decreased GCS, you have to insert NG tube. You have to check the weight. So if possible, put them on the weight bed to assess for the dehydration status. Okay. There is a strict fluid balance. Consider catheterization. So you can have this intake output record, biochemistry, monitor for the ECG for T wave changes, which are with changes in the potassium levels. Initiate the IV fluids and insulin. All right. So this is about shock resuscitation and non-shock resuscitation we discussed about. I'm coming towards that. IV fluids. Okay. What is exam important? IV fluid. You have to make them nil by mouth. Okay, for what purpose you give this volume of fluid? For what purpose? Because you have to re-expand the volume. Because the patient is in shock, you have to re-expand the volume. You have to consider this maintenance fluid, and first you have to correct the deficit, and you have to also correct the losses, which are the urinary losses, because urine has to excrete more ketones, so there is that loss of the water which is with these ketones. You have to correct that. So how you calculate the maintenance fluid and how you calculate the deficit, it depends on the, either you consider this is 5% dehydrated, all right, 5% dehydrated, or you consider this is 10% dehydrated. And I have told you it depends on the pH. If the pH is less than 7.1, 7.1, then it is 10% dehydrated, and if it is 5%, it is more than 7.1 to 7.2. All right. This is the deficit. How you do the maintenance? We did so many times in PEDS that for the first 10 kg you give 100 ml. For the next 20 kg, 10 to 20 kg, you give 50 ml. And then for additional, each additional 20 kg, you give 20 ml. All right. This we all pediatricians are familiar with. This is the formula of maintenance fluid, and deficit you can calculate with this Holiday-Seger formula. I am going to show you this formula. This is the formula, okay? What is the total fluid requirement? It is the deficit plus the maintenance. And how you calculate the deficit? How you calculate the deficit? Now look here. It is easy, okay? Percent dehydration, suppose 5%, you can either write 5 here or you can either write 10 here. Into body weight, suppose the body weight is 10 and this is multiplied by 10 in every child. So if a child is 10% 5% dehydrated and a 10 kg child, then this becomes 5 multiplied by 10 multiplied by 10. Okay, this is the deficit. And total requirement is the deficit plus the maintenance code. Okay, maintenance I have told you. You see the weight for the first 10 kg, it is 100 ml. All right. All right. If in shock, the initial 20 ml bolus which you have given, you subtract at the end that 20 ml. And sorry, you don't subtract in case of shock, but you have to subtract that 10 ml which in case of non-shock you have given the bolus. That you should subtract. This is now easy. Look, here is a 60 kg girl who is how many percent dehydrated? 10% dehydrated. pH is 6.9. It is less than 7.1, so it becomes 10% dehydrated. All right. This is the weight. This is the percentage of dehydration and multiply by 10. So 10 multiplied by 60 into 10. All right. And this becomes the 6 and along with this you divide over the 48 hours. This is the deficit and then you add the maintenance fluid along with it. If you divide it over 48 hours, then it becomes 125. For the first 10 kg, it is 100 multiplied by 100, it is 1000. For the next 50, it is for the next 10 it is 50, so it becomes 500. For the next it is 20, so 40 into 20 becomes 800. So divide this maintenance fluid over the 24 hours. Just add these two, this and this. You have to add these two. All right, you have to add this maintenance and the deficit. So this is the total fluid requirement. All right. Okay. For exam point of view, you see this potassium level, if it is less than 3.5, it is between 3.5 and 5.5, or if it is more than 5.5. If more than 5.5, then you don't have to give the potassium chloride, okay? No need to give the potassium chloride, just give the 0.9% sodium chloride. If it is between 3.5 to 5.5, give 0.3%. This potassium chloride, that is 20 millimole per 500 ml with 0.9% sodium chloride. And if it is less than 3.5, then you have to give this 20 and here it is 40 with the central line, okay, and with the monitoring. Don't remember that. Don't forget that, okay. This is the same thing I told you. All right, don't give direct. Don't give insulin bolus. Okay, this is important. What kind of insulin you give? You give the atropate, short-acting insulin, soluble insulin, 1 unit per ml in sodium chloride 0.9% via the IV syringe at 0.05 units per kg per hour. If no fall in glucose after 2 hours, then increase by 20%. If no fall after 4 hours, then from 0.05 to you will increase to 0.1. Okay. If blood glucose falls exceed 5, then you have to reduce the infusion rate and you have to adjust it. Okay. Do not stop insulin infusion. Do not stop. Check capillary glucose in 1 hour. If IV fluids and insulin given through the same cannula, use the anti-reflux valve. So don't give bolus. Do not add insulin directly to fluid bags. Okay, for task exams, sometimes they just ask you the names of this short-acting insulin that is like Actrapid. And also remember this long-acting insulin names: Glargine, Datamir, Degludec. This came in this 2023 task exam. They were just asking, select one of the long-acting insulin, and Degludec were among the options. Or they can ask you the short-acting, extra short-acting. So you have to remember the names of the insulin. Okay. When you switch when the glucose levels they are normalized, then you switch from this IV to subcutaneous insulin. And what is this subcutaneous insulin? What they say about this continuous subcutaneous insulin infusion pump therapy? They say you have to stop IV and then you have to commence this when blood glucose levels they become normal. Okay. Okay, so about the monitoring treatment, you check hourly blood glucose, blood gas, and then 4 hourly blood ketones. This is important. You have to check for neurological status and you have to check for vitals. Okay. You have to complete the summary sheet. Okay, all right. So what in the subsequent management? When blood glucose levels they fall below 14, then you can give orally a glucose containing food. So remember this value for giving this oral food. Whenever the patient is conscious and the glucose level it has fall below 14, then you can give this oral glucose. Okay. How you calculate this? More than 14, you don't have to give glucose because it is more. 6 to 14, 5%, and 0 to 6 is you have to give 10% dextrose. All right, if pH is more than 7.3, reduce insulin infusion rate from 0.05 if on 0.1. If on 0.1, you have to reduce it to 0.05. Blood glucose may rise as a result. Do not revert to sodium unless plasma pH falls. Wait for the pH. Okay, do not revert to sodium. If pH falls, reassess the deficit and the same regime. If glucose falls below 4, okay, give 10% glucose, 2 ml per kg IV, reduce infusion by 20%. Infusion rate by 20% and check 1 hour glucose. To make glucose 10% with sodium chloride, remove 50 ml fluid from the 500 ml bag of glucose. All right, for 5%, this sodium chloride 0.9% and add 50 ml of glucose 50%. Okay, continue with the IV fluids, insulin infusion until the blood ketones is less than 0.5. Okay, this much is enough for FOP exam. All right, whatever we did, this much is enough for the FOP exam. This is the base exercise. Okay, this is not needed for FOP or class exam. Signs of cerebral edema. Discuss other complications can be hypoglycemia, hypokalemia, systemic infections. You have to see for the lactate and the inflammatory markers and the culture. Aspiration pneumonia can be one of the complications we can ask in the exam. Okay, converting to the subcutaneous insulin. When you switch from IV to, this is the question, that when you switch from IV to subcutaneous. And another thing which is repeatedly coming in the exam, when you give oral fluids, when you give oral glucose, when you give with this infusions. So give oral whenever, remember this cutoff value 14. Okay, if it is less than 14, then go for the oral option. Okay, when you switch IV insulin to subcutaneous, they have written when ketones they become less than 1, change to subcutaneous, and when blood glucose is normalized, start on multiple daily dose injection 30 minutes before stopping the IV insulin. Inform the diabetes team, especially the dietitian, nurse, and the consultant. And if this patient is on pump, restart the pump 1 hour before stopping insulin. Change insulin cartridge and infusion set, insert cannula into new subcutaneous site. This is enough for this FOP exam. What you see on the discharge and follow-up, just remember these names: Aspart, Diabetic. Okay, this is Novorapid, and this Diabetic is the long-acting insulin. Okay, this is what you write on the discharge. You give the glucose gel. This is the oral gel for the glucose. You have to prescribe the glucose tablets. You should know about these options, okay? Because they constantly come in the exam. If they wish to give oral, then glycogel can be the best option. Oral gel is given. You can tolerate orally. Okay, so what's next? Yes, one thing, the sick day rule. Sick day rule is, there is a file of sick day rule. What they say about that, I will also share that in your group. It's not in my laptop, so I cannot share the screen. So what is the sick day rule? They say that whenever a diabetic patient got sick, ketones are produced in the body, and ketones are very dangerous because they cause, as initially I discussed, they make the pH acidic, very acidic, which is very bad for the body. Okay, so you never stop insulin if even the patient is not eating. Patient is not eating, but you have to continue the insulin. Okay, so never stop insulin if you are eating less than normal. Your body needs insulin to use glucose and get the body ketones. They say that check your blood ketones frequently, 2 hours, 2 hourly. Okay, check for blood glucose 2 hourly. Check for blood ketones 2 hourly. Keep hydration very well. Keep plenty of fluids. You can give water or sugar-free fluids if blood glucose levels are normal or high. And if they are low, then you must have to give oral glucose solutions, okay? And avoid carbonated. There is a table of ketones in which there is a negative ketone and an orange box, small to moderate, moderate box. Okay, I shift this to my laptop and then I can make a presentation so that you can memorize it, or either I will share it in the group. You can have a look. But the important thing we have covered this from the UK pediatric guidelines is diabetic ketoacidosis. Very important topic for both FOP and DAS exam. All right. So this was all about today's lecture. Thank you so much. Hope you understood each and every concept. Thanks for joining my lecture.